Morning, everybody. We'll just wait. We're just a couple of seat moves just taking place. So. Good morning, everybody, and welcome to the Shropshire Health and Wellbeing Board. For those of you that don't know me, I'm Simon Whitehouse. I'm Chief Exec for NHS Shropshire, Telford and Wricking. I'm co-chair of the Health and Wellbeing Board with Councillor Motley, and it's me that you've got in the chair seat this morning. So thank you very much for taking the time. Welcome to those online, as much as those in the room. Apologies for starting 2 minutes late. We're just aware we've got people sitting behind us, and so we've moved around because it's much better than looking at my back, I would imagine, for several hours to have people around the table in the conversations. I'm going to go around the room and do introductions. Be really grateful if you could say name, role and organisation that you represent, please. Just to remind colleagues that this is live streamed and we're live streamed now. So that's done over Teams, hopefully. And Carla, it'd be useful if you could nod. If you can see and hear me okay, that would be great. So that's a good start. I'll take the nod and the thumbs up as well. So I'll take both of those. Thank you. For those in the room, you all know this anyway, but if you want to speak, please indicate, and then we need to press the button to go red, then you're speaking, and then that makes sure it gets picked up with the microphones with the live streaming as well. We're going to go at a bit of a pace this morning. There's a lot to get through and a lot to cover. Whilst going at a bit of a pace there, I want to make sure we have the right conversations in the right areas on the right topics. So looking forward towards your contributions and your input. As with previous meetings, the agenda is structured. So we've got longer on the first agenda items, which are in the strategic items report for discussion bit. So we've got some time to have the conversations in those areas. And then as we go through the agenda, the intention is some of those are much more for information or for awareness, not necessarily for the same level of conversation and discussion. So hopefully that all makes sense and people are comfortable with that. That people are also now thinking, yes, I'm in the right meeting and I should be at the Health and Wellbeing Board, because if you're not expected to be in the Health and Wellbeing Board, you're either in the wrong room or in the wrong Teams call. So now would be a good time to leave. And then finally, I just want to go through and do the apologies that I've had, and then I'll go around and do the introductions. So I've had apologies from Leslie Brown. Hi, Councillor.
Hi, I'm so sorry I'm late.
Not at all. Apologies from Leslie Brown from Shropshire Council. Apologies from Claire Parker, NHS Shropshire, Telford and Wricking. Apologies from Stuart Bill, West Mercia Police. Apologies from Jeffrey from the voluntary sector. Apologies from Paul Kavanagh Fields, Robert Jones and Agnes Hunt. Apologies from Sarah Ellis Anderson, Shropshire Community Health, and apologies from Claire Horsefield, Shropshire Community Health. And also I've had a notification from Kirsty, who's said that she's currently in the schools forum, will be joining us as soon as she's able to leave the schools forum to come and join us. So I've not had any other apologies notified formally to me. Has anybody else got any that they would wish to raise? Louisa?
Yes, we have Ben Hollands and Lisa Middleton.
Thank you, Louisa. Okay, let's go around and do introductions, if that's okay. And I'm going to go round to, it's always a lucky dip, isn't it, in terms of which one? I'm going to go right. Rachel.
Thank you. Rachel Robinson, Executive Director of Health, Wellbeing and Prevention in Shropshire.
Hi, Susie O'Shea. I'm Head of Engagement at Energise. Jessica Bradbury, also from Energise, Head of Operations.
Morning all, Laura Tyler, Assistant Director for Joint Commissioning, Joint Auditor, Shropshire Council and Deep West.
Good morning, Tanya Marr, Executive Director of People for Shropshire Council.
Good morning, Louisa Jones, Business Support Lead for Shropshire Council.
I'm Michelle Dulson, Committee Officer for Shropshire Council.
Good morning all. Excuse me whilst I compose myself. I'm Councillor Cecilia Motley. I'm the portfolio holder at Shropshire for Communities, Culture, Leisure, Tourism. No, I'm not Leisure, Tourism and Transport anymore. Sorry, they put the wrong one there. I'm adult social care, public health and communities.
Hi, Naomi Roach. I'm the Programme Manager for Personalised Care for Shropshire Health. Hello, I'm Jessie Dixon, currently on placement with the council, helping support the development of prevention strategy.
Hi everyone, I'm Gordon O'Shane, Public Health Consultant with Shropshire Council, and here today in capacity as Chair of the Suicide Prevention Action Group in Shropshire.
Morning, I'm Heather Osborne. I'm the Chief Officer of UK Shropshire Television Weekend, but I'm here as Jackie Jeffries' deputy as a representative from the Voluntary Sector Assembly.
Morning, I'm Lynn Corley, Chief Officer of Health Work Shropshire.
Morning, Penny Basin, Head of Joint Partnerships. It's a joint role, Shropshire Television Week in NHS and Shropshire Council in Public Health.
Fantastic. Also appropriate for me to ask for interruptions for those colleagues that have joined us online. Now, this is a test of my eyesight from a distance. There's some that are easier than others. So, Carla.
Good morning, everyone. I'm Carla Bickley. I'm the Associate Director for Strategy and Partnerships at SAF, and I'm here today on behalf of Nigel Lee, the Director of Strategy and Partnerships.
Thanks, Carla. Gemma.
Hi everybody, I'm Gemma McIver. I'm Deputy Director of Operations at Shropshire Community Health Trust.
Thank you. Claire.
Good morning, I'm Claire Featherstone. I'm Head of Culture, Leisure and Tourism at Shropshire Council, here today to answer any questions on the physical activity paper.
And Laura.
Morning everybody, Laura Fisher. I'm Head of Housing Resettlement and Independent Living at Shropshire Council.
And have I missed anybody or not covered anybody who's online that wishes to introduce themselves now? No. Good. Okay. Thank you, everybody. I'm aware that with different people sitting around the table that aren't necessarily committee members, I would want you to feel able to contribute to the conversation and discussion. Not that anybody needs an invite, but let me make it really clear. I'd rather have a rounded, fruitful conversation. So if there's things that you feel on the agenda that you can contribute to and want to join in the conversation, the debate, I would ask you to feel free to be able to do that. I'm not expecting there's anything on the agenda that we need to vote on, but clearly if we got to a vote situation, I'm not sure I've ever voted in the Health and Wellbeing Board, to be honest, but then maybe I'm waiting for that one meeting. Then we will need to then just make sure we're really clear in terms of who are the members that are here and who are the ones that aren't able to vote. But looking at the agenda, I don't think that's going to be an issue. So we want people to feel as though they can fully contribute and join into the discussion. Okay, so I'm going to move us on then through the agenda, if that's okay. Disclosable pecuniary interests. So this is a reminder to all colleagues of the committee to make sure that members have disclosed any interests not already recorded in the register of interests, and to make sure that you exit from the meeting if there's an area where you've got a conflict or a disclosable interest. In terms of the agenda, does anyone have anything that's not already recorded or not already demonstrated elsewhere?
So I think, it's the local authority, but also the voluntary sector deliver on the Better Care Fund. So there are that item for agreement by the board, but it has, when we get to that item, it has been approved by NHS England. I don't think there's a real issue. It's just highlighting that.
So we need to record it, but I think we can manage that without you needing to step out as we get into that bit of the conversation.
And I think the winter support service as well, potentially.
Yeah.
Okay, thank you for that. Okay. So, didn't see anybody else indicating anything in terms of that. So, moving through then, agenda item 3, minutes of the last meeting. I would need your help here. I wasn't at the last meeting, so I'm looking for colleagues that were around the table. I'm going to do for accuracy first, if that's okay. I'm going to do this in terms of numbers of the page of the minutes rather than that's in the pack. So, page 1, page 2, page 3. Page 4, page 5, page 6, page 7, page 8, and page 9. Are people happy with those as an accurate record of the meeting that I wasn't at? Yep, thank you. Are there any actions on the accepted as a true record? So people are content that I'm able to sign these as the chair of the meeting. Is somebody able to second that, please? Thank you, Rachel. Are there any actions on the minutes that don't get picked up elsewhere or we need to update against? There weren't any when I went through, obviously, that either were outstanding or weren't getting picked up.
Don't think so.
Okay, so then move on to agenda item 4. Let me make sure I sign that.
Sorry, Simon, regarding the actions.
If you could press the button, Lynn,
Yeah.
please.
Sorry, Simon, regarding the actions. Following our report in the last session, it talked about providers letting us know what they were doing with regards to the accessible information standard, and I just wondered what the process is for that, because we haven't really heard from people what is happening, and so I just wondered if that would be part of this board, or if people would be expected to contact us outside of this meeting to tell us what they're doing.
Rachel.
I'm just going to make a suggestion that perhaps on behalf of the board, then we can write out to ask for those to be circulated and copy the board in.
Yeah.
So I think if we can follow that up, if that hasn't happened, we can follow up that action.
That'd be brilliant, thank you.
Okay. Okay, thank you. So then I move on to public question time. We've got 5 minutes. I have had one public question. And the person that's asked the question has asked that I read out the question and read out the response. So if you will bear with me whilst I go through this. The question received was from Mr. Darren Childs. Could we please find out what the current staffing levels are at Ludlow Hospital for nurses, healthcare assistants and domestics? Are healthcare assistants and domestics being told to watch patients and being put in charge of patient care when there are no nurses on shift? Could you also complete a staff morale questionnaire to find out how the staff are currently feeling and if they have any concerns, as it's my understanding that staff are leaving the trust quicker than they recruited, and there must be a reason for this. The response is received from Claire Horsfield, Director of Ops and Chief AHP and co-chair of the Shropshire Telford and Wrekin AHP Council, Shropshire Community Health Trust. She's got a longer job title than I. That must be a great door, though. It just means you get a bigger office, doesn't it? Current staffing levels at Ludlow Hospital for registered nurses, healthcare assistants and domestics. The normal staffing levels at Ludlow daily are morning, registered nurse 3, healthcare assistant 4, PM, registered nurse 3, healthcare assistant 4, night, registered nurse 2, healthcare assistant 2. Domestic capacity is used flexibly across the hospital site, but as an average, there's one domestic staff member on the ward between 8 till 4, 7 days a week. This increases when deep cleans or specific cleaning tasks are required. The second part then, the ward's never left without registered nurses at any time. The minimum amount of registered nurses on duty at any time would be 2. Healthcare assistants do provide care and supervision to patients on the ward, as this is part of their role. Patients that require enhanced support are assessed by a registered nurse and, if required, are placed on one-to-one supervision on the ward. This enhanced level of supervision could be undertaken by any clinical member of the ward team, nurse, HCA, therapist, therapy assistant, or a memory and wellbeing worker, and where required, additional staffing is sourced through bank or agency to ensure adequate cover. The patients then reviewed daily to ensure that the level of supervision continues to be appropriate for them. We do not include domestic staff in the supervision of patients, but as members of the ward team, they might alert a clinical member of staff if a patient was deemed to be at risk of falling. And the final section, in terms of staff morale, we are committed to continuously listening to all of our staff to understand their work, experiences, and how we can collectively make improvements. Our staff morale is measured through an annual NHS survey and national quarterly pulse survey. The 2023 National Staff Survey will be launching in October, and we'll use those results to measure the morale of staff at Ludlow and continue with our engagement activities. We hold monthly listening events with staff, which are attended by members of the executive and senior leadership team. A listening event has taken place at Ludlow Hospital, and we also have a staff suggestion feedback button available on all computers. We gather all of the data and information to inform our staff satisfaction and engagement agenda to improve morale. I'm going to take that as completed, if that's okay. So I think, and thank you to colleagues from ShropCon for that comprehensive response. So I think that moves us into the agenda proper. And that moves us on to the agenda item 5, which is the Send Action Plan update. Who's leading out on this? Karen joined.
Good morning, everyone.
Good morning. So over to you, but it'd be useful if you just do introductions as well, please, if that's okay.
Thank you. Yes, of course. So I'm Karen Lavelle. I'm the Service Manager for Special Educational Needs and Inclusion here at Shropshire Council. And I'm joined today by two colleagues from Health. I'll just let them introduce themselves.
Hi there, Jen Griffin, Designated Clinical Officer for SEND across Shropshire and Telford and Wrekin.
Good morning, I'm Tracy Jones, and as part of my role, I am the Director Lead for SEND, in addition to the title you can see behind me. And for the purposes of those who can't see that, that's the Director of Mental Health, Learning Disabilities and Autism.
Thank you, Jen and Tracy. So the purpose of this item then was to update the board members on the Joint Ofsted and Care Quality Commission Special Educational Needs and Disability Inspection revisit, which took place last November, and for the board to note the work that has been done to improve the SEND system, despite the challenges of increased demand and the financial pressures. So members will have seen the report that was sent in advance, and I just wanted to highlight the key areas for you to note. So the inspectors found that progress had been made in 3 areas, which were strategic leadership and planning, the inclusion of health services input into the area's action plan, and that leaders' actions to address the high rate of exclusions and suspensions for children with special educational needs had been successful. At the time of the inspection, the inspectors also found that further work was required to address 3 remaining areas. These areas to note are significant waiting times for children and young people on the ASD diagnostic pathways, significant waiting times for those needing assessment and treatment from speech and language therapy service, and also the quality of education, health and care plans. As a result of this, the local area was required to produce an accelerated progress plan, which was formally approved by the Department for Education and NHS England in April. That accelerated progress plan is published and is available to view on our local offer website. So, progress has been made with the actions detailed in the accelerated progress plan. We are monitoring that progress on a monthly basis, and currently no actions are read. Monitoring also takes place by the Department for Education and NHSE, both formally and informally. We've received an informal visit very recently and no concerns were raised, and the formal monitoring is due to take place at the start of November, and it will be 6 monthly thereafter. I would also like to point out to the board that Shropshire is one of 4 local areas within the West Midlands to be selected to work on the SEND Change programme. So as members are no doubt aware, following the publication of the government SEND and AP improvement plan, there are 9 regions across the country that will be testing and designing aspects of that system. And therefore, this board may wish to consider requesting information and an update on the developments in relation to the Change programme. The Change programme is due for official launch next week on the 19th of September, and the programme will run for around 2 years. So I'm just going to hand over to Jen now, who's going to talk you through the diagnostic pathways for autism and speech and language therapy.
Thank you, Karen. Hi, everyone. So firstly, in terms of our work around the ASD and ADHD diagnostic pathways, we have the challenges of long waits as referenced, but there were also challenges identified in the re-inspection around communication and access to service. This is in the national context of very long waits across the board. So the average waiting time for ND diagnostic pathways is over 9 months nationally. And then after that, a further 7 months on average to receive treatment, which is particularly pertinent to the ADHD clinical pathway. We know that nationally we have a limitation in terms of workforce and particularly specialty workforce, and we are also in the context of societal and particularly media interest in diagnostic labels. It's at the forefront of the public's mind, and with that there's a national increase in referral rates to these diagnostic pathways. So in terms of our local approach, we have been trying to address it in twofold way. One of those ways being ensuring that as a local system, service and support can be accessed without the requirement of a diagnosis. This is all in line with the Waiting Well agenda and meeting needs, like I say, without requiring diagnosis. And then additionally, work has been done to clarify their diagnostic pathways and improve timeliness of access. So we have worked as a local system across Shropshire and more recently Telford to clarify what is available to our children and young people and their families whilst they're waiting, improve practitioners' ability to signpost and navigate families to those services. We've committed, and Shropcom have been really on the front foot with this, we've committed to supporting families through advice lines where they can pick up the phone and ask for advice from our Child Development Centre, from our speech therapy services, physio, OT, etc., which has been a really welcome resource and use of resource. Work has also been going on to support education settings and early years settings to better meet need regardless of diagnosis. We have managed to clarify access routes to diagnostic pathways. So the narrative around accessing services for diagnosis is changing. We now have the narrative that actually we can get into those services, but then we still have long waits once we're in those services, which is an improvement from back in November where there were still challenges getting into the services. And particularly from a MPFT BU perspective, we have been putting resource into supporting those who are waiting, who may have escalating need to avoid crisis. So the impact of this has been a greater understanding across the sector in terms of what is available without diagnosis. We have services working together in an effective forum to support children and young people. Schools have reported that they've really valued the training and support which has been increasingly and is being increasingly offered to them. We can see statistics and we're, like I say, hearing the narrative that it is now easier to access and get on the waiting list, but there are still long waits. As mentioned, there's extra resource from a BU perspective of supporting children and young people waiting. The additional roles there just came in the summer, so we're still waiting a little bit to understand the impact of that fully. And we have we've had increased funding into the diagnostic pathways to complete additional diagnostic assessments, but it is evident that the demand is still outstripping the capacity given the increased demand that we have locally. In terms of next steps, we've got a commissioner focus on this part of the provider contract to address capacity and move forward to ensure sustainable progress with the waiting times. We'll happily take questions at the end, but I'll move on to speech and language and communication, if that's okay. So our challenge was around waiting times for speech and language therapy services, and we had very high referral rates. This is in a national context of long waits for speech and language therapy being commonplace across the UK, and also really variable commissioning picture in terms of the service offer and how it's commissioned across the country. Again, our local approach has been to support children as well as possible whilst they're waiting and ensure that everybody has a role in supporting speech, language and communication needs at a universal and targeted level, as well as addressing the access to the services in a timely way. So we have had quite a long-standing robust working group with Shropshire and Telford and Wrekin to address the support at universal and targeted level for speech, language, communication needs. We've worked to publish the offer of support available using the iThrive model and other mapping tools. Again, the offer of support around having someone to talk through an advice line has been really welcomed by the community. From an education and early years setting, we've rolled out Talk Boost and other approaches to ensure that those settings have the skills and the resources required to support language and communication at the earliest opportunity. This work has been done in a highly co-productive way, which is not acknowledged and valued from the system. And there has been ongoing prioritisation of children and young people on the speech and language therapy waiting list who most specifically need the unique support of a speech and language therapist. So they are clinical pathways such as dysphagia and dysfluency, where the speech and language therapist is most fundamental to supporting that child or young person. From an impact perspective, we're seeing a changing narrative. We're seeing increased confidence across the system that speech, language and communication can be supported by all. We are seeing the benefits of the early intervention and prevention approach and the impact of talk booths, which we have both qualitatively and quantitatively. This has resulted in a reduction of referrals for the speech and language therapy service, which is very welcomed, but still the demand is outstripping the capacity of that service. We have the continued effective triaging and prioritisation of those who most specifically need speech and language therapy, as I mentioned. So in terms of next steps for speech and language therapy and speech, language and communication needs, there's ongoing commissioner focus on the provider contracts, the capacity and service specs. This includes exploring the joint commissioning position. And we are also anticipating some possible developments in the pipeline through the change programme, which we can't at this stage fully talk to, but we hope in the next couple of weeks we will be far more appraised in terms of possible opportunities through that SEND change programme, which is just launching next Tuesday, so all very new. So Karen, I'll hand back to you in terms of EHCPs.
Okay, yes, thank you, Jen. So a similar story in relation to EHCPs. So what we know from the national context very much is that there's some gaps in external provision and training, a lack of coordination between services and weak co-production and a lack of accountability. What our local feedback has been telling us is that around the inconsistency of the quality of the input from education, health and care. So that is in relation to the advice and reports that are collected prior to issuing an education, health and care plan. There is a lack of an effective quality assurance process, and very importantly, the EHCPs have not been updated or issued in a timely manner, which has caused a lot of frustration. So the work streams, similar to what Jen was saying about the other two areas, work streams have focused very much in these areas, and the work has been ongoing in terms of focusing on a person-centred information, exploring the digital platforms that will be available to support this, co-producing, and that's very important, co-producing the new advice and annual review templates for when we're reviewing education, health and care plans for all agencies, rolling out a joint workforce training programme, reviewing our arrangements for social care contributions to strengthen that input, reviewing our commissioning arrangements and updating our service specifications, developing a revised induction and EHCP plan writing programme for our SEN case officers, developing multi-agency quality assurance processes, and reviewing our capacity across the teams, including educational psychology. We have in place what we call an annual review recovery plan, which is our commitment to review all the existing plans in the system, as well as actually looking at the new plans in terms of the quality of those. So in terms of the impact, our timescales for issuing new education, health and care plans are now more or less in line with the national averages. And a lot of the work to date has been around setting the actual infrastructure in order for us to produce the good quality plans going forward. So the focus has been on terms of the design of the processes, using co-production, looking at the different paperwork, and a huge focus on the training of staff. So there's been significant investment in workforce training, especially across the social care partnership. So we're measuring the quality of our education, health and care plans, both through our quality assurance process, but also supported by surveys with our families, our children and young people, and our professionals as well. So the most recent survey has literally just closed just last week, so we're in the process of analysing that in order to look at the impact around the work that we've been doing. So I'd just like to conclude really in terms of this item and ask the board to note the report, but also to commend partners in the partnership for their work in terms of delivering improvements to date across the SEND system. And also to seek assurance that the partnership are doing all they can to promote, support the experience and outcomes of our children and young people with special educational needs. We'd very much like the board to identify any key areas of concern where board members could support further, and anything that you would like to talk to us about, if there are further areas of improvement that you would like to actually discuss with us. We'd like you to also perhaps consider scheduling an update on further progress around the action plan, especially following our visits from our formal monitoring visits, and also with the work that's actually ongoing in terms of the change programme that's just about to launch. Okay, thank you.
Thank you, Karen. Thank you, Jen, and thank you, Tracy. I can see that Councillor Hurst-Knight wants to go in, so I'll just bring her in a second. Just to say, look, really comprehensive, both in terms of the paper and then the update, and then going through the recommendations. Anytime you want to come and chair this meeting, feel free. You can take my role because you've done it for me. It helps massively in terms of that, so thank you for that. Councillor Hurst-Knight, as portfolio holder, it'd be really great to feel.
Sorry, apologies. I've just jumped from school forum to here, so apologies for being late. And this may have been covered, so but obviously I was going to echo Karen's comments about the partnership working and moving forward. I think that's got to be, really stressed that that's been a real success. And the meetings that I've been involved with and chaired, I really want to say thank you to everyone, because it's only in coming together that we're going to find a way forward. One question I do have, and probably know what it's going to be, because I always ask, are the ICB considering additional funding for our mental health services? Where are we at with that? I know we discussed it briefly last Health and Wellbeing, or maybe the one before, but sorry to put you on the spot, Jen, but do you know where we are with that? I know business case was going forward. Thank you.
I'm mindful that we haven't specifically spoken about mental health services because that doesn't feature as part of the APP, but Tracy, is it okay if I hand over to you to respond to that question?
Yes, of course, no problem. So in terms of the business case so I'm just going to step back one moment, Councillor, just really to get a sense of your question, because I haven't heard you ask it before. So okay. It's just really understanding in terms of our broader mental health spending, or the mental health spending relating to the areas within the SEND plan.
You're on mute, Councillor.
Sorry, there seems to be a bit of a delay on my mute today. Some people will be happy about that. It's just generally mental health funding for our young people. I know that we were very low on the general, on a regional UK basis, but obviously the mental health support within the SEND community is vital. So will there be extra capacity? Is that what I'm asking? Thank you.
So in response to that, I will share, and I don't know if it's been shared before at Health and Wellbeing Board, but I'll arrange to the latest information around our profile in mental health spending to be shared with Health and Wellbeing Board members, because I know quite often people talk about some data that was shared a number of years ago, and the position has changed slightly as we move forward. In terms of the amount of investment into services, we will always continue to review that as an ICB. And we do have an investment process, and part of the work that we've been doing in this area, and I think Jen may have alluded to it earlier, is we've strengthened our commissioning arm, and that will help us in the way that we're set up to actually start looking at some of the data behind our commissioning intentions, and therefore help us work together as a system to build those investment cases as we move forward. So I think one of the strengths that we have seen that will address both the SEND and your wider question in relation to mental health is the way in which we've changed and strengthened the commissioners who will be leading this piece of work. So we would expect those commissioners to be leading across the system in looking at those business case developments.
And Councillor, I mean, as chair, but also as chief exec of the ICB, I can probably come in and further support Tracy's response in terms of this. So I think your question is a really fair and valid one. and we absolutely will go through the prioritisation process for next year's planning round in terms of what does that look like. We do meet the mental health investment standard, which is the ask in terms of the level of funding that goes in. Tracy's alluded to the fact that at times there was reference to a level of funding that was several years ago. Is the funding where we'd want it to be? No. If we look at cumulative growth from 18-19 to 23-24, what the local systems put in is circa 20% higher than the national average. Now, we were starting from a really low base, so even being 20% higher than national average means we're playing catch up in that process. But you know, I think that shows the additional level of growth going in, but we're starting from a low base, which makes it really challenging. From the work that we're doing, we're continued to focused on continued investment in this area. We will, of course, meet the mental health investment standard, but we know we need to go further. Previously, it's been talked about the ICB, the ICS being the lowest funded in terms of that. When we last looked at the analysis of the mental health investment spend per head of population, we were ninth from the bottom out of 42. Not where we want to be, but again, significantly further up than where we were when it was first quoted and first referenced. So those are just some of the facts and figures in terms of the background of that. But do not hide. I don't hide from the fact in that we have more to do, and we want to get the balance right in terms of where we spend our money. And we know that the mental health challenge across Shropshire, Telford and Wrekin, and for children and young people remains a significant one. Questions, comments on so Penny first and then Tanya.
Oh, thanks. I was just going to say, when listening, I was thinking about at our last Health and Wellbeing Board, we heard about our integration work and thinking about the development of family and community hubs, and just really welcome further outside of the meeting conversation around how we build in the work that you're doing into that local work in our communities.
Thank you, Penny. I think that's really is particularly pertinent. I know it's something that's been raised quite relatively recently within our SEND sphere, so there's absolutely the appetite to build on those opportunities.
Thank you, Penny. Tanya?
Thanks, Simon. To build on Simon's comments, congratulations team. It's a lot of work that's gone on pre-inspection and post-inspection. It was great to see that our inspectors were assured that 3 of our areas of concern that we'd made significant progress. And though we do know that those remaining 3 are both a national problem as well as a local problem. And certainly what I'm picking up from parents and from professionals in particular regarding the speech and language work, there's been huge progress made since the last inspection. So I'm sure our inspectors will see that when they come in again in November. So my question's around demand and capacity, and we know that across the board demand has gone up. And I'm just interested from a Health and Wellbeing Board member about what work is being done to really understand the demand moving forward, because that position is changing, has changed, is changing, and just want to ensure that you've got the right support around you to get a good picture on the data and moving forward around the capacity. Thank you.
I'm happy to answer that, and then maybe Jen and Karen can come in on some of the issues. So in terms of that data, demand and capacity, I think that we're in a much better position than we were when the inspection happened in November. Certainly getting the lists, understanding what that profile of the additional demand is looking like, we definitely have a better grip on that. In terms of the wider discussion about where this demand is coming from and how much will it continue to grow, so how much do our services change in terms of the capacity? So in terms of trying to understand whether we're going to reach a point where demand will level out, because it has been, the level of growth has been exponential in terms of our ASD, less so in ADHD. But I mean, we still have that waiting list of 52 individuals across Shropshire, Telford and Wrekin for the ADHD, but a much larger list of 741 ASD children across Shropshire, Telford and Wrekin. We're working with the regional, who are in turn working with the national teams to look at this pattern of demand, because it is at the moment not understood whether it will continue or whether we are just seeing a peak and that it will level off. So we've certainly got a better grip on our own data, and we're reaching out and working with our regional colleagues to understand both how that data is growing and then answer the question of how do we deal with those growing numbers. Jen mentioned in her presentation, her talk today, actually looking across the workforce. So when we talk about money and we talk about understanding our demand, the next part of that is understanding how we address it and how do we get the workforce to conduct these assessments. And just want to share with everyone that actually here in Shropshire, Tafton Reeking, the work we're doing about not needing a diagnosis but being able to access support is actually one of the key things that when I speak with national and regional colleagues about this, that's being advocated, because we won't be able to immediately provide services to bring down these long waiting lists. It's about how do we manage those people on the waiting lists, and how do we ensure that we've got the processes in place that the individuals who need the assessments the most are being prioritised and being placed on the waiting lists. And that part of the work is work that we've started since the inspectorate came in November, and that's the work we're doing with regional colleagues in the regional medical directorate to understand what it is we can commission differently in terms of the triage around those assessments as well. So I just want to give you, Tanya and board, the assurance that we have got a different level of understanding. It was one of the things that the inspector spoke to us about and noted that we didn't have that grip on what our numbers were, or a programme of work to look at how we were mapping that demand and capacity. And we've started that with our providers. Our business intelligence leads are working with the provider leads to look at and understand that demand profile. And then we're also working regionally and linking in with national leads on how do we work to get the capacity to address those assessments.
You okay with that, Tanya? Okay. Response to pick up some of that. Rachel, then I'm going to move us on the agenda. Okay.
Yeah, thank you. It's just a final point on that, and really it was linked to the data and the outcomes that you were mentioning. I know with you obviously allude to some of the national outcomes and waiting times and the challenges around data just in the last response, Tracy, but I think it would be really helpful through SHIP, but then also as we develop the dashboards around for the Health and Wellbeing Board to have oversight and have that view of what's actually happening, the long-term trends and the impact that all the fantastic work is having. So I think we do need to, I support bringing this back, but in the meantime, if we can look at building those dashboards and those measures, so we can have that kind of oversight of the impact this is having and where we perhaps need to support further. So it was just on that point, bring it back as well in terms of the GSNA and understanding need as we get that granular level of detail. Can we map those indicators together, which will help us with some of the other programmes like the integration projects we're working on.
Thank you, Rachel. Okay, I'm going to bring this agenda item to a conclusion, if that's okay. So, look, firstly, I think you've heard from board members, and it's in the paper, and we recognise, listening to the three of you present, the bit that comes through on this is the partnership and the joint working, and we just need to continue to strengthen and build that, because the solution to this and the support for our children and young people will be around absolutely integrated, joined up working, where we deliver that in partnership. Not one organisation has the solution to this, and nor should it. So absolutely recognise that and would encourage that to continue to build. Secondly, let's recognise the work in progress that has been made and recognised by the inspectors, but more importantly, the points that Tanya pulled out, the points that in the presentation around what young people are saying, what parents are saying, what professionals are saying in terms of some of the changes. Absolutely recognise the work that's still to be done in this area and the focus that we still need to bring to that, and the paper sets that out very clearly, and I think that's important. And absolutely the Health and Wellbeing Board will want to receive an update on that, as well as the update on the change programme that Karen you talked about as being one of the exemplar areas in that regard. The other piece for me is I'm always worried about waiting times that are deemed to be hidden. So there's a lot about how long does it take, does it wait to get your hip replacement or to get your x-ray done or to get your scan done. Actually, often these are hidden waiting lists, and we need to be talking about it, and we need to be working through that demand and capacity piece that Tanya and Rachel and Tracy you talked about, because we need to understand where that demand's coming from and how much further down the downstream or upstream can we get in the work that we do to put that support in as early as possible for our children and young people in this area. And I think the approach around local data with the dashboard, with the local place board in terms of SHIP picking up the conversation and looking at how we continue to widen and strengthen that partnership is really positive as well. So recognise, accept the paper in full, accept the recommendations with a couple of those additions that I've added in from the comments that have been made, and thank you for taking the time this morning to bring the updates to the Health and Wellbeing Board, and more importantly, thank you for the work that you and colleagues are doing to make a difference to the lives of children and young people across Shropshire.
You're welcome. Thank you very much.
Thanks very much. Bye now.
I'm going to move us on if that's okay, and we're moving to the suicide prevention strategy, and Gordon, I'll come into you.
Thank you. And apologies, I do have a bit of a cough today, so I'll try not to cough into the microphone. But I'm very pleased to bring to the board our draft Shropshire Suicide Prevention Strategy, which has been refreshed for this year. And the intent for bringing it to the board is to get endorsement, and obviously if there's any comments or suggestions that you feel could enhance the work of the suicide prevention programme, that would be greatly received also. So the strategy has already been out for stakeholder consultation, and we've had some great comments back. So the version you have is the most up-to-date version. It has been co-produced by our multi-agency suicide prevention network, which sits across Shropshire, Telford and Wrekin, and it builds upon the work of the first suicide prevention strategy that was launched in 2017. So just as a quick reminder of the outcomes from that strategy, the creation of a multi-agency action group to have that focused discussion on suicide. What can we be doing to improve outcomes for those who have been impacted by suicide in our region? The launch of a dedicated suicide bereavement service, and the launch of a survivors of bereavement by suicide group as well, which is recently set up in Shropshire and Oswestry. We've launched dedicated training delivered by our joint training team on suicide risk, interventions to build confidence, knowledge and skills across our workforce and within the community and voluntary sector, as well as a range of awareness events, campaigns, resources such as Pick Up the Phone, You're Not Alone, and online dedicated information which can be accessed via Healthy Shropshire and the ICB Suicide Prevention Resources page. So our vision within this strategy, as I say, is to build upon the work that's previously been undertaken. It's still very much with that focus on we want to reduce the number of people who take their life. That is our ultimate vision. Our mission statement is that suicide is preventable, but it does rely on all of us being aware, early identification, early support that can, appropriate support that can be identified, and that every life should be saved. We do have a zero suicide mindset. That is our philosophy. And it's not a performance target, but obviously that is where we would ideally like to be. We do know there's no one reason for suicide, and no one agency can be completely responsible for the success of the programme. So it does need that commitment to partnership working with the community, with the wider system, and influencing society in the broader context as well. So the key messages from this strategy are very much around promoting greater awareness and conversation about suicide to tackle stigma. It's often still seen as a taboo or difficult topic to bring up, and we really want to address that. And also to encourage anyone that is struggling or has been impacted by suicide to reach out as early as possible. And just to remind people, there are people, offers, services who are ready and able to listen and help. So I don't want to go through everything that's already submitted in the report, but just as a quick reminder of the priorities outlined within the updated strategy. We've come from a place where there's been more of a focus on universal offers, but we recognise that there are certain groups within our communities which have higher suicide rates compared to the general population, and they could benefit from a more tailored approach in terms of messaging, interventions, the type of supports that we can make available. So therefore, we've decided to focus based on local and national evidence on the higher risk cohorts, which include men, people who self-harm, children, young people and young adults, people who are already known to services where suicide has been identified, particularly within mental health services, our rural and farming communities, the military veterans community, people with protected characteristics, so that would include our LGBTQ population, people from different ethnic backgrounds, people with disabilities, and also neurodiverse conditions as well. And then wider social risks, recognising that actually, as I say, this strategy, although it is focused on what can we as an action group and system do to directly influence and target positive outcomes for people struggling with suicide, that link with wider risks such as financial insecurity, problem gambling, substance misuse, domestic abuse, housing issues, criminal justice. These are all really important things that sit alongside this strategy, and we want to ensure connections with wider programs of work that are already taking place. In addition to the high risk cohort group, as I say, more integrated working to improve inequality linked to emotional wellbeing and mental health needs is a key component of the strategy, improving access to the right support at the right time, enhancing our data and intelligence for monitoring progress using that evidence base for looking at what interventions could be most impactful for that population at the right time. So building upon our real-time suicide surveillance, also establishing suicide death learning reviews as well, so we can learn from what has already happened, what were the circumstances, what are the opportunities to work with partners in the wider system to put recommendations in place to hopefully avoid something similar happening in the future. The evolving continuity and sustainability of our suicide bereavement and postvention offers, continuing our workforce community education, training, awareness and skills offers, particularly with a greater focus on intervention and what that could look like for different parts of our workforce or within the community, and also around comms and messages. What are the most appropriate or the right messages that we can connect to the right people to have the best impact? So underlying all of this, an action plan is being created by the Shropshire Suicide Prevention Action Group. And to help us deliver this, because as you can see, there's quite a few programs of work that sit here in high risk cohorts. So we have set up subgroups of the action group, which we're calling work streams to focus on those particular topics. So some of this will be specific activities, task and finish type actions. Some of it will be around influence and how we can influence other programs, streams of work or the wider system. But what we do recognise is actually we do need buy-in and support from our partners, from others who already work with those high-risk cohorts, who have those insights, who understand those challenges, to really help us explore where those shared ambitions could be. What can we do to strengthen outcomes, not just in terms of suicide prevention, reducing inequalities and improving the lives of those individuals, but also how can we do that with limited resources, limited people, money, etc. as well. So would really welcome that conversation. And if anyone would like to support any of that work or be involved with the conversation, please do contact me on the details within the report. So just to finish off quickly, so as I say, this is a Shropshire suicide prevention strategy. So previously it was a Shropshire Telford and Wrekin strategy, But based on stakeholder consultation feedback, we did feel actually having a dedicated Shropshire local authority area focus strategy would be beneficial. It gives us the flexibility because we do have quite a different demographic to our Telford colleagues. But just to reassure everyone, we still will operate as one Shropshire, Telford and Wrekin suicide prevention network, and there's still partnership work that's going on, particularly with our suicide surveillance, bereavement service and other opportunities as well. We have chosen a 3-year period for this strategy, mostly because when this document was written and shared, we were still waiting for the National Suicide Prevention Strategy to be published. It was published this Monday, so there you go. What I can say is that our local ambitions are aligned mostly to the national. We were aware of the themes that were going to be in the national strategy, and actually in most parts it does resonate with what we're seeing locally as well. The only, dare I say, thing to consider is there's still some uncertainty about the funding commitment to take forward this work. So initially, when the strategy was first launched in 2017, there wasn't an allocated budget for this programme. We don't have a dedicated suicide prevention officer, so a lot of the early days work was carried out by goodwill from partners who were part of the action group. We were successful in a funding grant from NHS England, which has helped us develop and deliver activities over the past 3 years, but that is coming to an end March 2024. So in the national strategy, they have not gone into much detail about funding and what that looks like. Just to have on the radar, it's the continuity specifically of our suicide bereavement service. That is delivered by our voluntary sector colleagues from Shropshire Mental Health Support and Telford Mind. So it's just that mindfulness. If we don't have certainty within the next few months around funding for that, we will have to consider alternate options, should we say. So just wanted to have that on the radar of the board as well.
Thank you, Gordon. Really comprehensive, and the paper and the strategy that's in the pack really clear. I like the 6 actions, how that's set out, and the focus in terms of that. There's a few bits that I want to pick up. I'm going to open up the floor wider in the first place. Tanya.
Thank you, Gordon, and I completely endorse and welcome the strategy. So thank you. Completely needed for Shropshire because our demographics and the rurality of Shropshire ensures that we're focused on Shropshire population needs. And my question's around objective 3, which is around suicide risk aware. And looking at your action 5, can you just describe to the board the what are we going to do to ensure that that people of Shropshire understand what they can do if they are concerned about somebody, and particularly a professional, if there is a carer out there that is under a lot of stress and pressure and is saying things of concern, what would that professional do in terms of contacts? I think we need to be a bit more clearer about what we do.
Yeah, absolutely. And again, there are some resources that have been developed which are available on our Healthy Shropshire webpage. So if you are supporting somebody who is struggling with suicide ideation, there are some initial contacts, guidance information about what you can do, who you can contact. Obviously, it depends on the situation of the person and the age as well as to where you would be directed. But as an initial quick reference resource, the Healthy Shropshire webpage, advice around suicide ideation is one place you can look. Also, we've just recently launched a first point of contact for concerns around mental health and wellbeing in a broader context document, which is also available from the Healthy Shropshire page, and again gives some brief advice as to what you can do, what you can say, who you might want to contact. But absolutely recognise if there are specific concerns, I would welcome the conversation to explore what more we could be doing to ensure the right confidence is available.
That's helpful. Thank you, Gordon. And clearly, the pick up the phone, you're not alone. Suicide prevention, Z cars are out there. People get that, understand it. We've all seen it on the bridges. I think it's the other stuff that I worry about in terms of our professionals really aware of what support services are out there in Shropshire, and what can we do differently as a health and wellbeing board to ensure that those messages are out there in our communities.
Thanks, Tony. And I was going to pick that up as well, because it talks about how do you make the Zero Suicide Alliance free online training mandatory as part of all professionals. So I just wonder how that action gets, is that action being picked up by providers separately? How are we progressing that, and what can we do, given the people around this table and online, to pick that up? Because I think it's probably the two bits linked together, Tanya. Actually, we should have, we almost need to make that the mandatory training with the local blend of, and so locally this is what you would do as a result of, and this is what it would look like, and if we build that in, then you get to a different place.
Yeah, absolutely. And again, I think this is where we have the opportunity as local authority at NHS, if we can build in mandatory training and set the example to the wider organisations as well. I do know within Shropshire Council we do have the Zero Suicide Alliance training on our Leap into Learning, but it would be, we would really welcome if it could be part of mandatory training, and absolutely building links to the resources for further information as well.
So I think there's an action there, isn't there? Because otherwise we'd like it if. So I'm going to ask NHS provider colleagues if we could have a system conversation in terms of what that looks like in terms of mandatory training, as well as what a local module might be to add to it in terms of what do we do. And I would ask partners to look at that in the same way, as well as an explicit action that we can capture, because otherwise it'll be a yes, we'd like to do it, but we'll never get the traction on it, if that's okay. So I've got a number of hands up. So I think it's Heather, then Rachel, then Penny.
Thanks, Gordon. I don't need to press that again. A couple of things. The first one was in terms of the sort of multi-agency network and the development of the strategy. Has there been much involvement from GPs in this? Because obviously that will often be the first point of contact that people will be going to. So are they engaged and involved and know how to send those people to the resources that are there? So I think that was my first question. And my other was follow on from Sam's comment really about training, in that if we're looking at training, I would make a plea to consider some training for voluntary sector organisations as well, because we are seeing increased numbers of people contacting us, expressing suicidal thoughts, and that's something that for some organisations has not been the norm, and so it's quite difficult for staff to deal with that. And also we often have great difficulties in then trying to link those people into professionals elsewhere to get any other support and help. And I'm also particularly concerned about things like the police no longer doing safe and well checks, and the difficulties that we have if we are worried about somebody out in the community of who we can get to go there. So it's just a plea to kind of wrap those things in as well.
Good. I'm going to take a couple of comments if that's okay, sure, and then pull this all together, and then we can pull that in one place if that's okay. So I've got Penny, Rachel, Lynn, and then Councillor as portfolio holder. I'm going to come to you for bring some of this together as well, if that's okay.
Just very quickly to remind that it really leans into a lot of the work that's already going on. So the integration and hub development, obviously, but also the Armed Forces Covenant. So we've got a whole sort of swathe of work there, and a board that meets. So just as long as we start kind of feeding that in, we don't have to reinvent the wheel. We don't have to retrace our steps with those groups. We can just lean into what's already going on with this work, I think, and that sort of does help solve some of the availability resource to deliver. Thanks.
Rachel.
It was just commented, I think about 4 years ago as a board, we said that we would show leadership and undertake the training. So I think there could be a refresher, and I think that would be a statement that we could all make. I think I agree in terms of the training offer. We've also got the cost of living work, and through the social task force it's been picked up. I mean, you've already alluded to that in your report. So again, I think that's another forum where that would be welcome. So I think the ask from the team, another action from the team, is to bring together the training with the local offer, and then to hold that onto all the other work, and to come back to this board from all of the organisations to look at what the timeline is to make this mandatory, but our own leadership around that. And another thank you for the document. I think it's very clear, excellent, simple, brought together, back to the team for all the work that's been done with very, as you said, this is partnership working at its best, the art of the possible, bringing that investment in, and I pick up the ask around the ongoing funding that we all need to consider through this work, which you've alluded to before. So we'll take that away outside the meeting.
Thank you, Rachel. Lynn?
Thanks, Simon. A couple of things from me. Because one of them is an ask of the board, really. So I did apologise to Gordon when he came in, because I do tend to contact him a lot about this issue. But one of the reasons for that is because I was 17 when my first friend committed suicide, and he shot himself while he was on duty with the military, unfortunately. So it's something I'm really passionate about, and I've also worked with a lot of young men in further education, and also, you know, just having elderly parents. I've got one of those who is regularly expressing suicidal thoughts. So I think it touches so many parts of our community. And so one of the things I've been doing is there is an ICB workforce health and wellbeing lead, which I've linked in with Gordon on this, because obviously there is a workforce issue that is connected to this. So, you know, I'm really glad that I was able to make that connection. But interestingly, on the 1st of September, I went to HMP Stoke Heath, which is just outside Market Drayton. And it was a care leaves event for men who were due to be released within the next 12 months. And it was, the idea of the event was that services would be there to speak to these men about what would be available to them when they left. And half of the services didn't turn up. And there was only one, there was two services and me. And one of them was a substance misuse service and one was a hepatitis C service. So everyone else came to me as Healthwatch Shropshire. And they were, each of the men who came to me was terrified of being released because they didn't know what was going to happen. They were asking about housing, they were asking about mental health support, and they shared some really traumatic childhood experiences with me, which I don't think I'll ever get over, that have led them to the life that they lead. So I suppose my question to the board is, what is the relationship of this ICS with that prison? It's the only prison in Shropshire. I spoke to the two mental health nurses yesterday who are regularly are releasing men who they know are suicidal into the community with no support. And in the last couple of weeks, two of those men have killed themselves immediately after leaving prison. And so I think the question is, bearing in mind that the prison is in this county, but a lot of the men in that prison will not live in this county, but some of them will. It's about how we can, as a nation, wrap around these people to help them live safely when they've left prison, because you just need to go and speak to them about how they feel about that. And it wasn't new to me, because as Healthwatch we get a lot of people who call us who feel like this because of their desperation and their frustration with services. And I just think there's so much more that needs to be done.
Thank you. Brings to life, makes it real. And actually, it's not just a report and it's not just a strategy. And so really appreciate that in terms of the story and the real lived experience piece. And there's a few bits, there's some important points in there that we can't lose from the conversation, from the discussion as well, that we just need to capture. So thank you. Councillor.
Thank you very much indeed. First of all, I'd like to say thank you to Gordon for producing this report. I've been working with him a bit on this. I think it's an absolutely excellent report, and I think his recommendations we really need to take seriously and push on through with. The problem that we're facing is that we've got a very large county. We've got limited resources, and we have different age groups. We have a whole gamut, really, of age groups that are affected, particularly by suicide. And trying to deal with each grouping appropriately, I think, is quite a difficult one. which I think Gordon is very much aware of. So I'm not sure that an overall approach is necessarily going to be the right one right the way through, because it seems to me that there may need to be different approaches depending on who you're dealing with. You wouldn't deal with a child, for example, necessarily in the same way as you would deal with a farmer, for example. But actually, it does seem to me that one of the other really important things about this is that people understand that there is help out there and there is support out there. And I'm thinking particularly among, as you know, I always end up in the rural areas, don't I? But it is a fact. In my own division, we have had some really tragic suicides affecting the farming community. And one of the things about this is the fact that it's terribly shocking, not just for the family, but also for the community itself, because a lot of rural communities are quite close. They tend to know when things are going wrong within a family setting, but they don't know what to do about it. They don't know who to get hold of. It does seem to me that it would be a really good idea to try and work on communication with these groups. And I'm thinking in particular, if we're looking at the farming community, for example, using the resources that are out there, organisations like SALT, for example, to actually ensure that people know that there is a point of contact for them, which they can go to without prejudice, as it were, in order to raise this issue up the agenda. And it's something that I will certainly be talking to all my parishes about, because I think it's terribly important, and because we really do suffer from this in the rural areas. And the current situation that people are living in is actually putting more pressure. It's not lifting pressure off, is it? So I really would urge Gordon to think very much about how you start down at the bottom with this, as much as how the professionals go about dealing with it, because I think we can learn a lot from the communities as much as the professionals can advise, get together, etc. So I think that's really my message, is let's try and make this as holistic as possible if we can, not just taking it from the top down, but looking very much from the bottom up, because I think then we will get a much better wraparound of this particular problem.
Thank you, Councillor. And actually, that echoes from a different part of our community, exactly what Lynn was talking about in terms of where do we start and where does this come from, as well as then links to Tanya's point of what can we do from professionals and staff and awareness, as well as though thinking about how do we engage with our communities differently and what does that look like, and connect into that, wherever that community might be, actually, in terms of that. Gordon, I'm not going to come back to you to ask you to go through that, because a lot of those were comments rather than specific questions, but I think there's some really important points there that I'm sure you will have heard in terms of picking that up and taking that forward. So I think there was a few actions that came out as we were going through the conversation discussion. In terms of the strategy, there was I think the board are absolutely endorsing it and wanting to pass on our thanks to the team and colleagues that have been involved in getting it to the point that we've got it. There were clear actions linked to the action plan, too many actions in that sentence. To make sure that we get into the delivery of that strategy. I think there is certainly an aspect in terms of the points that Lynn's raised and Councillor Motley's raised with regards to the link to our communities. So I also think there's a ship responsibility in this as well, then, in terms of how we manage some of this and talk about it, and how do we get this into the place-based agenda around that. And there's an ask in terms of some of the training for professionals for us to look at that in each of our organisations around our mandatory training piece. And we'll probably be in a future conversation about the funding aspect that you flagged as well. So I hope from that I've captured the nature of the conversations, the discussions. Thank you for bringing that this morning, Gordon, on that. Is there anything that I've missed or not covered, or any final words that you wanted to say that I've not picked up yet?
Just very quickly, just to remind people that our joint training team are suicide first aid accredited, and we are able to provide that training offer at a subsidised, or in some cases no cost to the delegate, particularly within the community voluntary sector. So if we are aware of anyone who could benefit from this training but hasn't had access to it yet, please do put them in contact with me and we can have that conversation. And then just very, very quickly, DHSC have established a suicide prevention grant fund specifically aimed at the voluntary community sector. It is to support suicide prevention activity. The deadline is 1st of October. So if anyone is interested in that or is already looking to put a bid together, please contact me.
Thank you for that, Gordon. And we're not on the formal agenda, but we're going to get into the wider prevention conversation in our development session. I'm just thinking how it links to this conversation, and we need to pull that out as well when we get into that space. Gordon, thank you very much. More than welcome to say, but equally would understand it. Thanks very much. There's a surprise. I mean that politely. Everybody does the same when they're presenting now. Thank you very much for that. Then. Great conversation and discussion. Thank you, colleagues. Okay, we're moving on. Agenda item 7, physical activity, including Beat the Street. So Susie, Jessica, Penny, I had to do a double take of that because I looked at the screen and I'm thinking, it's telling me Susie's on the screen in front of me. I'm looking to my right and Susie's sitting there as well. I'm like, that's really impressive. I can be in 2 places at once. Who am I coming to first? Who's leading out?
I'll start the context, yeah. Thanks very much, Chair, and thanks to the board for taking a report on physical activity. As you can imagine, there are plenty of things that we could include in that. So we're going to do a presentation now. Are you all right to share the presentation? But just to sort of set a little bit of context, I will assume that everyone has been able to have a look at the report, which is great and includes a lot of detail. Our colleagues from Energise are going to take us through some of the great work that's going on, and then also pose some questions to the board about how we can really increase physical activity in Shropshire. So for a bit of context, this report is timely because within the last few weeks, nationally a national strategy was produced, Get Active, a strategy for the future of sport and physical activity. So the government's obviously been busy producing strategies. The national strategy retains the 5 outcomes from the previous strategy, which was around physical well-being, mental well-being, individual development, social and community development, and sustainable economic development. The priorities of the new national strategy are driving participation and addressing inactivity, strengthening integrity and sport, and making sport more sustainable. Go to the next one. Okay, from the national strategy, it also highlighted some evidence, and then locally we have included some insight in the report as well. But nationally, it really that strategy talks about reducing the number of inactive children and adults and how it reduces the burden on the NHS and social care. Every year, active lifestyles, it says, prevents 900 cases of diabetes, 93 cases of dementia, and delivers a combined savings of 7.1 billion to the UK economy. So we can see that those physical activity is really important. And we can appreciate the national strategy because locally we understand that we also have a significant number of people who are inactive. So data tells us that. And the paper highlights that the inactivity level can be improved by sustained input, which is why we included things like Beat the Street, which demonstrates that evidence base that says when you input into support for people to access activity and to do more, people do more. And when you support that a little bit more, people continue to do more. So that's really important for us to think about. Then if we go on to the next slide, I just put this map up. This is from our leisure services colleagues who are also on the call. Claire has been with us to talk about this as well. And just to highlight that actually, as a local authority and as a local authority area, we have a wealth of things at our fingertips. We have lovely outdoor spaces, we have leisure facilities, we have all kinds of things that help people, that can help people to get active. However, as the report states and the previous slide states, there are people who still have barriers to getting into that activity. So what is it that we can do to address that? So over to Energise to talk a little bit more about the fantastic work that's been going on, and then to talk about what more we can do.
Thank you, Penny, and thank you for inviting us along to the Health and Wellbeing Board today. So the report is quite wide-ranging in terms of all of the work and all of the areas that Energise are involved in. So it was quite difficult, to be honest, to select a couple of things to particularly highlight, but it was a welcome to have the opportunity to share the whole paper with you. So the things, and it links directly on from what Penny was saying. So firstly, to talk about the Green Social Prescribing project, which actually comes to an end this November, which there's been a lot of talk about partnership working this morning, and this has been a real success over the last couple of years with NHS charities together, Telford Wrekin Council, Shropshire Council, Sport England's Tackling Inequalities Fund, of course Energise, and the Shropshire Wildlife Trust. And the mission of the project was to bring together, and it's exactly to use knowledge, connection, skills, passion. You can read all of the mission there, but it is that point that we are so lucky, and I don't think a day goes by where I don't talk about how lucky I am to live in this wonderful county. But not everybody does have access to those places, and not everybody understands the benefit of it. Not everybody knows what we live and breathe around this table, around the benefits for physical and mental health of just very small things and just a very small amount of time, particularly in a green space, and what that can do. So this project is all about that work, and the report shares some of those findings. The next phase is really about going forward from the 2 years. Is currently being scoped and will be based on all of the intelligence that we've gained across the last 2 years. But I shall hand over to Jess to tell you a little bit more.
Just need to turn the frame.
Okay, perfect. Sorry, tech issues. Thanks very much for welcoming us, as Susie had said. I just wanted to highlight a few of the key findings from the Green Social Prescribing project. Which won't be new to you. You know, the kind of 3 L's that we've rounded it up, something that will hopefully stick in your mind in terms of our lovely acronyms that we have in our worlds. Those 3 L's are local, low level, low cost. You know, for people in the community, that those hardly reached communities, those experiencing the most inequalities, is what we can do to look at how we can not only connect people to their green spaces, you know, make them more aware of what's out there in the communities for them. So there's been that highlighted need for greater public awareness on what's on people's doorstep and how that links to obviously the social prescribing system in terms of connecting people better, but also for the social prescribers themselves to be more connected to green spaces and the local community that they're serving. Thank you. So one of a couple of examples of how the project has been able to kind of bridge those gaps has been produced in this Let's Go Outside brochure, which highlighted 9 different walks or 9 different areas across Shropshire, Telford and Wrekin, which highlighted key bits of information to help bridge that visual barrier for people. Actually, what am I expecting when I turn up? What does it even look like? Are there benches for me to access? Are there toilet facilities? Kind of simple things for people to help them understand, you know, how they can connect with that area and obviously helping their emotional and physical well-being. Another example has been bench-to-bench walks, where our Green Social Prescribing Officer has been able to understand the infrastructure needed in order to create that walk, and has been able to expand that. So actually there's 5 new bench-to-bench walks. I don't know if anyone is aware of the bench-to-bench walk in concept, but it allows people with limited mobility to that kind of first step outside, where they know the meters or the steps involved between those benches, where they know they can get adequate rest in between those walks. So she's been able to expand on that as a real kind of practical example of how some of the learning, some of the collaborative working and that kind of co-creation with local community groups and green spaces to kind of land that opportunity locally. So those were just a couple of examples. Obviously, there's been various challenges that have been highlighted along the way, and just to kind of highlight a few, as I've already mentioned, really, that better awareness of local provision amongst kind of social prescribers, as well as the time for them to actually go and visit that opportunity themselves, and, you know, for themselves to understand that connectedness and that benefit for themselves. It allows them to actually portray that to the clients that they're working with. a strategy for green social prescribing is needed and should be shared so all stakeholders can see the aims, areas of need, the meaning that interventions can be designed and actually those that also meet demand, advocates at all levels of the system as well, and the possibility of a green social prescribing steering group for Shropshire, Telford and Wrekin could be set up to share that learning, drive forward its development and be accountable for the implementation as well. The last point there was around a green activity providers network covering both Shropshire and Telford and Wrekin could facilitate that sharing, learning, improvement and increase the effectiveness of providers as well, because we know there are so many green activity providers and how do we then connect them together, especially to the system. I'm not going to waffle on, I'm going to pause there, if that's okay. And we're just going to lead on to another slide. Susie's going to...
Yeah, we're moving off green social prescribing into another area of our work. So maybe we can discuss everything after because I'm sure Claire may want to come in on a point of that. So it's just to move on to another area included in the report about work within schools, and this has been absolutely fascinating, and there's so much learning coming out from a piece of work that we've been involved in over the last 2 years. So anybody that's known Energise for a long time will be able to remember back to where quite commonly going back over sort of 5 to 10 years ago, people would know us for school games and being very much about sport and very much, about big events at the sports village and getting all the sporty kids together to come along and have a great time. And there's nothing wrong with that, and there's still a role for that. But really, that is so far away from the Energise we are today. And this work with schools is the Creating Active Schools framework is the best example of that. And what this is all about is less than half of children are currently meeting the Chief Medical Officer's guidelines of 60 minutes of daily activity. So sometimes schools think about that as 30 minutes within school and 30 minutes out of school, but just an hour of being active. It doesn't mean an hour of being sporty. An hour of being active a day is the Chief Medical Officer's guidelines for schools. But obviously schools have a completely different agenda, don't they? Schools, are increasingly and more and more pressure on academic attainment, and physical activity for them is seen as, just an add-on and not seen as integrated. But what this framework has done is provided a whole system approach where it's really not about PE at all. It's about the whole school and what can we do. So yes, we want effective PE lessons, and we want, person-centered approach to how PE is conducted, to think about all of those children and young people in that PE lesson. But what we actually need is the whole school. How does the child safely arrive at school, and how can that be helped? What happens during school? What's going on in a maths lesson? Does it need to be somebody stood at the front and everybody sat down as we're doing, or can that be done in a different way? What opportunities there at break time for all of the children? What happens after school? So it's the Creating Active School framework is a process that one of our colleagues has been working through with targeted schools. We're currently working with 13 schools in the Shropshire local authority area and 5 in Telford and Wrekin, using this framework where every single member of staff, so not just the teachers but the whole staff, are involved in thinking about this. There's been some really amazing outcomes. So yes, 100% of schools have reported that physical activity is increased, but back to that point where the school's priority is not about physical activity. Schools care about behaviour, and they care about social skills, and they care about attendance. And what we have proven through this framework is that, and you can see the statistics there, 93% of schools reported on pupil wellbeing. So I couldn't help reflecting on this when Gordon was talking, because there's that obvious connection there of the impact on wellbeing. But behaviour and the obvious implications for that for schools, 73% of schools reported that pupil behaviour is improved, and 80% social skills had improved. So an 87% where it's really become a daily habit and built in to that whole school day. So it's a fantastic piece of work, and we've been capturing in the early part of this year, going round, another one of my colleagues doing little videos to capture what the schools are saying about this. So this is a short video which hopefully the tech will work. It's only 1.5 minutes long. just to give an example from one of our schools in the county.
Actually changed in school as a result of the changes that you've made to the timetable?
So the biggest change is we don't have a fixed timetable for break times. Whereas most schools would go out at a set time with all the children going out together, we actually go out when the children need that. So the teachers gauge that as part of the lesson. And if the children are looking like they need a bit of a break from something, they might go out earlier in the morning or later in the morning. And that really helps them to remain focused, and it's really helped with supporting behaviour and attitudes to learning in school. So what we've done is we've built in an extra 15 minutes of activity during the day, and that is broken up across the day to give children lots of different activities that they do. It might be daily mile, it might be skipping, it might be activities in the classroom, but it just breaks up the day.
So how do the teachers use these additional minutes of activity that they have now?
Lots of different activities. Sometimes it's a few extra minutes in the classroom. They might do some Zumba or some clubbercise, and we've had some videos especially made for us for that. But they also do daily mile throughout the week. We're starting a skipping competition where the children skip daily. They go out, they play table tennis. We've got a zoned playground where they'll do football, they do basketball. And it's lots of different things that work for the children on any given day.
So it's just a little insight. We've got lots of these different updates from different schools, but I'm just going to pass on to Jess to tell you a little bit more about the programme and the work.
Yeah, I guess there's a question at the top there. Can this model work in other systems? You've no doubt kind of seen that frailty scale before. Those that remain active and strong as they age, they obviously have a decreased risk of health conditions or a severe kind of health event as they age, and again that kind of risk of falls decreases as well. So it's almost looking at that model from that kind of early life, where what CAS, the Create Active School framework, is trying to achieve, which is young people having a positive behaviour towards being physically active. Well, actually, how can we support that in adult life and older life, and how can we replicate this framework to support with that onset of health conditions and obviously falls as people age as well. I just give them a clip. Thank you. So again, these facts probably aren't new to you in terms of you're twice as likely more to be inactive with a long-term health condition as without. 1 in 6 UK deaths, preventable in terms of physical inactivity, and then 40% of long-term health conditions again prevented by reducing inactivity. So you've seen in the report the benefits of physical activity as well. And then the cost savings that were in the report and that Penny alluded to, that 7.1 billion in terms of its contribution to ill health and driving up healthcare costs, as well as ill health to the workforce. And then in addition to this, it's been estimated that the sport and physical activity in the community can generate 9.5 billion of value. So again, something that we'd included in the report as well. And that's 5.6 billion of healthcare savings and 1.7 billion of social care savings. So again, back to the framework. No one is exploring this in terms of an adult kind of social care environment or kind of a workforce specific environment. It's a framework there that's been designed. It was in Bradford as part of a local delivery pilot, so there was a lot of investment going into that area. But is this something that we could almost explore a bit further around the workforce or around specific settings? Like I said, it's been used as in an education kind of setting, but actually there's other systems where physical activity could be embedded in terms of the ethos, policy and culture of that organisation to again look at prevention in this kind of preventable way. I just wanted to add finally that we are actually hosting an event on CAS, specifically the Creating Active School Framework, on the 25th of September, so in a couple of weeks' time at Guildhall. It's a morning event just to kind of share what the findings are and actually those next steps as well. So I just thought I'd share that, and if you want to connect with us, Susie's details are on the report.
I think we have some questions for you on the next slide, don't we? Should we just show all of them all at once? Question for the board. So can we show them all at once?
Yes. Try.
Read them through.
There's no questions for the board. So could the education framework used in the education system be replicated in health social care settings? Could public services consider adopting a similar approach, making physical activity part of our workforce culture every day? How do we bolster the together we move as a movement? How can we get more? How can we do more to support people to access the physical activity assets and programs that exist in Shropshire that our green prescribing program have really highlighted, and that exist across our local authorities? So thinking about, thank you, thinking about our culture, leisure, and tourism. We have a lot to offer, and what should our goal be? What should our metrics be? We know we're kind of in line nationally with inactivity. Well, what, collectively, what is our goal? Thank you.
Okay, so there's a lot in there, but thank you. Thank you for the information. Thank you for the update. Thank you for the questions. I guess my intention Penny, would be, I think we can pull the questions out in the conversation discussion rather than try and go through them systematically, but I want to use them as the basis of, so what next actually, in terms of where we're at. And when I was, previous life Chief Exec in Cheshire, I worked with, it was then Active Cheshire. I was a trustee with Active Cheshire in terms of how did we get into tackling inactivity rather than how do we make fit people fitter, which is a similar theme that you're talking about. And I met with Peter Ezard and Andy Taylor a couple of weeks ago, who's Chief Exec, I think, and in terms of building on this and how do we support this. So from an ICB's perspective, this is an area that I'm really personal interest in and personal focus on, because of the bit that you showed at the end in terms of the impact on long-term health conditions, the impact on decompensation, frailty, all of that. The evidence base is really clear, and we don't promote that and push that enough. It's got a better evidence base than some of the mitigation and some of the interventions that we use, yet we'd still prefer the drugs and the interventions rather than the evidence base around exercise and mobility and movement. You don't need to speak to me from a convert point of view. I'm always going to be a sponsor from this place anyway, and a supporter in terms of that. So comments and thoughts initially, and then let's do so what next? So, Kirsty, I thought you'd got your hand. I saw you got your hand up earlier.
Yeah.
I thought they were going to ask us how much activity did we do a day, so I quickly took it down. A bit honest there for a politician, but there you go. No, it's just to really link in with you. Fantastic work you're doing with school, and see you on the 25th. But just additionally with Shropshire Council, we've been doing a lot of work around the rail project, bikeability, reinstalling the old-fashioned walking bus to school. So there's a lot of work going on there. Safe School Street. Just think outside of this meeting, it'd be really good to have a conversation and let you know what we're doing. So it's that culture shift from, really early age. You get out, you get walking, you get moving, and there's so much work we're doing with active travel. So it'd be really good to tell you what we're doing so we can tell you the schools we're working with, if that's okay.
That'd be great. Thanks, Kirsty. Yeah, sorry.
Thank you.
Thank you. Heather.
Yeah, thank you. I think all the work with the schools is fantastic, and Beaton Street is brilliant as well. But I'm really interested in that cohort, sort of 50 plus, because I think that's something now lots of us slide into inactivity, speaking personally. But, how do we get that cohort of people up and staying active? And I think, the statistics in terms of what stops people, I think it's really interesting that 35% of people are saying it's work-life balance. And then we've got 34% who are saying health issues. And I think, the people we see, there's a mixture of either confidence, lack of confidence, if people have lost that ability, particularly after the pandemic when a lot of people have become even more sedentary, but also motivation. And it's that bit about motivation. And I just think maybe there's something about working with businesses and employers about the workforce, because I think the stuff the schools are doing is really, really interesting, but lots of us as employers know about our staff health, well-being, all those issues at the moment. Is there something we could be doing in Shropshire, which is about working with employers to say, let's have times when you get your workforce up and moving?
And I think that should be one of our starting points. And I think that picks up on your second question, which is, could public services consider adopting a similar approach in terms of physical activity? I think if we don't set an example and demonstrate that, then actually, how can we ask others to do it? And then I think that flows into actually what do we ask of employers across. So if we start there and start to work with our employers and start to, but we need to set an example as a public service area as well in terms of what does that look like and what does that mean. So I think we're not going to solve it today, but equally, I'm also thinking of the prevention conversation we're about to have and what does this lead into. It absolutely ticks the boxes in this space around how do we build on that. So I would agree, Heather, entirely around that. Lynn, and then Laura, and then I'm going to look to pull us together.
I'm going to smile because I really do support this, this whole ethos really around activity. But I also know that since I left school, I've become a sloth, really. I mean, I used to do all the sports at school and now I don't do anything. And I barely walk the dog more than 5 minutes a day. So I think as an employer, I've probably should be a better role model for a start, and my team are all better than me at this. But I think it'd be really helpful to have some guidance on how we could incorporate that into the culture of what we do. I do try to do walking meetings, but if it's a bit drizzly, maybe I don't do it. So I just think some ideas would be really useful for what that could look like. Yeah, because I know my team would be up for it, and I'm sure they'd drag me along.
And rather than answer the question specifically, I think it's that how do we get into, I think there's the work that comes out of this, linked to the prevention conversation we're going to have, that does the, how do we combine our forces and combine our efforts to give those examples and start to promote those. So rather than try to go around the table now and do I think we should do this, I think your question's absolutely spot on, Lynn. And it's where does that happen? Because it can't happen in this board isn't the right place for it to happen, but we need to be having the connections and the conversations, the discussions that, that links Kirsty from the schools work that's happening, that links then in terms of the prevention conversation. Maybe it is after this meeting when we do the prevention conversation, that's the informal part of this meeting, where we do the, how do we start to set that example and what are the bits that we can, what are the hints and tips in terms of how do we build it into work and what does that look like? Because otherwise it'll be a nod, yes, we know we need to, but I'm not going out in the rain because it makes a mess of my hair. I can say that. Okay, really helpful. Thank you. So, any final comments or thoughts? Oh, sorry, Laura, I didn't mean to miss your apologies.
No, not at all. And just to say, Heather, it's probably 40 plus, not 50, because myself and Catherine 100%.
You're showing off now an age then.
Yeah, exactly. I think, but I do think there is something exactly as you're describing, Simon, around that. How do we pull some of this together? So from a commissioning perspective, how can I work with our providers to really link together maybe the schools and to do some of this work, to make some pledges? But I think in terms of that together we've moved, never heard of it. Actually, so is there something about, having a targeted month where we start from there and do, right, these are the actions right across the sector from, employment, from schools to provide, so we start that movement. But I think we've got to start really ramping up a campaign that does that element of work. I am even, I'm a mother of 2 children, and actually it's too easy to communicate through technology. So how do we link that from the schools, into the home environment where we just say, right, put the tech down, that's that 30 minutes. So I think there's just that, trying to square a bit of that around how we monitor that and then I think parents are very conscious of that. So there's an inroad there. But it's about pulling all of this together. because I think there is a lot going on, but is it centrally one place? I think you talked about an action plan. I don't know if it needs a strategy as such, but just some pledges, 5 pledges as a system, and what are we doing about that is all it's needed. I think don't overcomplicate it.
And that would then support a commissioning framework. Then you can say when we're having the commissioning conversations, how does this service or this offer align to the pledges that we as a Wellbeing board have made or public sector partners have made in terms of where we're trying to get to? Yeah, okay, good, helpful. Claire's got a hand up, and then I'll come back to Penny for final comments, and then Penny to move us on. We need a bit of catching up agenda-wise, but I wanted the conversations on these areas to flow because there's been really good conversation. So Claire, on Teams.
Yeah, so I'm just wanted to say a little bit about green space provision in Shropshire. There is an automatic assumption, because we are very lucky to live in such a fantastic rural county, that there is a plethora of accessible green space, and that's really not true. When we look across the county generally, the green space with facilities is very few and far between, and that's why Attingham Park, for example, is one of the top 3 visited National Trust sites in the country. So there is some work that we're looking at to try and think through what that sort of master planning approach to green space areas, particularly close within or close to our urban areas, making sure that the quality of that green space on your doorstep is really going to help encourage people to get out of their car and walk, and it fits in with the whole active travel agenda as well. So we're looking to recruit at the moment a green infrastructure advisor to help with the planning system to really improve the quality of green space that's coming into our new developments, but also to think more about the master planning approach to green space, because I think there is something really, really fundamental in how we take that work forward for the generations in the future, to make sure that we have got the infrastructure to make sure that people can keep well.
Really, really good points, Claire. Thank you for that. Penny, final words from you, and then we'll start them together.
Thanks. So I just, all of the input is great. I think we have a wealth in the county, and I know, as Claire has said, there's more to do and there's things. But if we look at if we take the insights and the data and we pull that together with what we've got, and we as Laura said, around taking some pledges and working collaboratively, I think we can make some really fantastic inroads. And I do think the starting point is with ourselves, and then moving that forward and actually just ramping up that campaign, as Laura said. So I think we've got what we need at our fingertips, and because people have told us why they don't engage, so we can do something about that. And a lot of it is around cost. So actually free facilities, that's what's needed. So anyway, that's it.
So, in terms of next steps then, on this, so I think we need to develop the pledges. We need to have the prevention conversation that says, how do these conversations start to happen in one place rather than in fragmented disparate pieces? So Jessie and Naomi are nodding at me from the other side of the table. And so we need to pull that together. I think it's worth the Health and Wellbeing Board having an update in a couple of meetings' time that does how's this starting to hang together as a framework that we are starting to demonstrate our leadership in this space, because I think this is a really important area and we need to give it the sponsorship and the profile bit as part of the entirety of our prevention approach for the residents of Shropshire. And then I think that gets us into what's our responsibility as an employer, what's our responsibility as individuals, and how do we get into working with that adult community that Helen talked about and Lynn, you talked about, in terms of our responsibilities around that. So then that gets us to develop the action plan of actually what are we going to do that's going to make a difference in Shropshire in terms of increasing that level of activity across the board. And I think that's a really important thing that the Health and Wellbeing Board should absolutely have on its agenda and keep tracking and monitoring. Does that give us a way forward? Are we okay with that?
Yeah, sounds good. Thank you.
Yeah, you okay with that? Yeah. Yeah. Now, again, more than welcome to stay. And actually, the prevention conversation might be a really helpful conversation to stay for if you weren't intending to stay otherwise. But equally, if you've got other calendar commitments, we'll understand that as well. But thank you. Okay, thank you. Good. Okay, I'm going to move us on then, if that's okay. I'm running slightly behind, so we've got a little bit of catching up, but this is our last main discussion item, and then the items after then are we go through in a more faster speed, famous last words. But that's more of a hint to the people who are leading out those agenda items on the agenda. So, Joint Commissioning, Winter Support Service and Prevention Commissioning.
Laura is taking this one.
Thank you, Lauren.
Yeah, thank you. And apologies that Lisa can't be here today, so I'll try and do it justice. But actually, what it's doing, it fits in with a lot of discussion that we've already had, so it ties in really well. So there are two elements to the report. One is the first element is really an update in terms of the last year's winter support service and some of the really good outcomes from that, and how that's really informing where we want to move forward. So I think it's useful just to point out that so for last winter, that was the third time that we actually commissioned a specific winter sports service. Every year that's been evaluated, reviewed in quite a lot of detail actually, and every year helps inform what the next year is going to look like. So I think it's really important to notice. So you can see that when you've got highlights within service. So for example, last year we incorporated mental health support as part of that, and again, very much based on what's already been said today. It's very much done in collaboration with VCS partners, really great service. I won't read all through those details, but I think it is just, and you've got a lot of detail around within the report around some of the outcomes around that. Just to highlight a few things, I think, which is useful. A huge amount of referrals, from November to 31st of March, 249 referrals. So the highest in December, and actually we saw a huge increase in comparison to the previous year. So again, every year it's getting more popular. Age range is again really interesting, as you point out there. So the 70, high majority of those individuals 71 and above, with the majority being between the ages of 81 and 90. Again, and it links in, I think, to our discussion around mental health and wellbeing. A high proportion of those referrals, so 176 of those live alone. And again, I think that's been really highlighted in terms of the isolation, mental well-being, and also that kind of link to that exercise and the wider well-being as we've described here. So we do know what was part of the last year, we did put a wellbeing officer into our FPOC, which is our kind of a front door. So you can see the highest proportion of referrals coming from that. Now that is for a good reason, because of the changes that we made there. I think there is something about, wider communication, particularly to our health colleagues, that we did have an increase in referrals coming from the, from the hospitals in particular, but probably not where we probably want it to be. So there's some work that we need to do, and I know the teams did this, because I absolutely know they did, when and had discussions with the IDT, which is our integrated discharge teams, but I think there's a bit more work to do around that. Currently, we have got a proposal for some winter funds to support this, to ensure that we're doing this. I think the key thing here that we want to really do, though, is to have this type of service all year round. I think we talk about winter pressures, but how many times there isn't winter pressures? We are constantly, as a system, under pressure. So there's something about how do we bolster that service and embed it as part of, which leads me nicely into the next element of the report, which is around our general wellbeing and independent advice service. So that is funded through the Better Care Fund. It's very much focused on preventative work that we've got. We are currently reviewing that as part of the Better Care Fund elements of one of the themes underneath that. So at the moment, the current scope, as you can see, consists of quite hands-on support, so practical help in the home, friendship and support, day opportunities, and again, that keeping well and keeping active element that we've described earlier on. So it's a really, really well-used service, we know that. It's delivered by a consortium for the voluntary sector of providers that you can see there as part of the report. We've got to look at the contract that currently expires in March 2024, but there are other areas that we need to ensure that we're reviewing and looking at whether we can align some of that. So that's why we've got the advice, advocacy and welfare benefits support service there. There's a lot of alignment in terms of that concept of that one Shropshire at that front door element, looking at a locality based level and making sure that we are delivering across the Shropshire plan, but also the forward plan as part of the ICS and the ICB board work that we've done collaboratively. So that all of those elements taken into account, we're trying to look at how we effectively pull together a service specification that's much more better fit for purpose and moving forward. That's a big piece of work to do. I think that there's, and a lot of people around the table have been involved with that and will continue to be involved with that. I think in terms of those recommendations and really where we're moving forward is really that buy-in as a system to say, let's look at what we need rather than what's budgeted for. Because as a commissioner, that's where I start from. What's needed? Where's the demand? And what are the outcomes? And how we can use that in most efficient, effective way. So we're starting from that parameter, and then let's look at how we manage that collectively as a system. So I think I'm not going to go into any more detail on that. Just to say, you know, you've seen some of the good casework, case studies that come out of that. You know, the numbers are there. We know in terms of that investment into, you know, in the voluntary and community sector, we just get much more value for money. But it's ensuring that, you know, from a system perspective, that this type of system, you know, and the service specification or whatever we want from the service is meeting the needs of individuals as well as the system part of strategy and priorities. I'll leave it there and just go for further questions.
Do you need me to step out while having this conversation? I think possibly I've got a conflict of interest.
I don't think I was public meetings. We haven't asked for any decision to be made today. Sorry, but it's your job to say that in a minute. I'll be quiet.
But you've already done it though.
I'll be quiet from now on.
You were going to say what I was going to say, but it's fine. So I'm comfortable. No, not at all. Not at all. I'm comfortable that you don't step out at this point if other colleagues are, because there's not a request at this point in terms of, as you say, the decision or funding or other bits. And actually, I'm comfortable that we'd have the conversation anyway, and it's slightly bizarre, of course, with a hybrid meeting. Even if you stepped out, you can just log in on Teams. So let's just be realistic about how we manage that piece. So I would be comfortable to have the conversation in front of you, because literally you could step outside, join on Teams, and then be watching it live streamed anyway. Which sort of defeats the object. The bit for me, Laura, on this was there was just so much in there that I just wasn't cited on because there was so much. And then trying to take the time to work through all of that, and then you say, so how do we make sure that we can demonstrate the benefits? It felt like so big. It's like difficult to say, well, that bit's making a difference here because there was so many things, which is great because of that offer and because of the numbers. I certainly thought the piece for Carla and Gemma to pick up is how do we get the NHS referral route right? And I don't mean as a formal referral, I mean as in a signposting direction piece, and how do we use IDT, how do we talk to our PCNs from an ICB perspective as well, our primary care networks, so that people are aware of what's available and the routes through into that. So I think there's an action there for us to pick up across the board in terms of that. Any other questions or comments on this as we sit here now? Heather.
I would say one thing, if I may, which is that I think it's really useful to look at it going forward in terms of whatever happens around preventative services for the future, because obviously at the moment, the current preventative contracts, the general idea is to keep folks away from your doors, really, so that they don't come through that route. But at the same time, I think what's been really useful with the winter support service is working with the teams in the first point of contact. And it's how do we, when you do have those people who are coming through your doors, how do we have a sort of prioritisation system that you can say, we need to just scoop these people up because they have come through that route, while still trying to stop them coming through that route in the first place, if that makes sense. So I think there's a conversation to be had there about the best way to do that going forward.
Okay. Thanks, Heather. Carla, on Teams?
Yeah, I fully support the work that's been going on. I guess my comment would be, in terms of making this sustainable, what are our plans to do that, and how will this then fit in with our capacity and demand modelling for the system? Because I think that will then start to shape some of the services and the provisions that we want to commission moving forward over the next 12, 18 months. But where we are at the moment, we can't afford to lose any of the services that we've currently got, can we? But I do think we need to be starting to plan ahead and look forward based on a true capacity and demand model for the system as to what our requirements are moving forward.
Thanks, Carla. Laura?
Completely agree, Carla. So I think some of the work that we've got going on, with system partners, so we've got some external support looking at that demand and capacity work. So thinking about, the percentage and the numbers that we've got through those pathways that we knew we've got. So that's from an internal perspective, but also looking at it from a community perspective as well. So it's not just a hospital focus, it's obviously those trying to prevent them coming through in the first place. So you've got that kind of two-pronged attack, which is really, really important. I think sustainability is a really, really important question. And I think, we've raised it here before in terms of that investment from a system. I think we all need to be joined up to that. And when we are looking at the VCF and looking at where where the value for money is, we may have to make some brave decisions about some of that and where that goes. And I think we need to have an hard conversation about that collectively. We know there isn't any more, more money. We're all struggling in terms of our own deficit. But I think if we can evidence the value for money, I think it's you to say, Simon, the outcomes that we've got, and then say, and collectively agree where that is put in place. And I think the Better Care Fund is a system, it's our pooled funding system, isn't it? It's something collectively, is a system that we do together. It seems to be the area where I think it should be the focus. So hence why, we need to be reviewing that collectively. So Carla, we can come and pick your brains on that.
Yeah, I definitely think our system capacity and demand model will give us most of the answers to what it is that we need to invest in moving forward, and it will also help to move the resources around, get more services at place based, and obviously review what providers currently provide.
Thank you for that, Penny, and then I'm going to move us on.
Thanks. I was just going to say, I think there's a real opportunity for us to do, and I think it will just be a follow-on from what Carla's just said about the demand and capacity, but to look at how we do the winter planning and how we could take a risk on that, because we get winter planning funding every year. So rather than starting when we get confirmation of the funding, how to start and just say, well, we know we're going to get it, so let's actually create this up front and figure out what we're doing up front. And keep it going. So I think there's real opportunity. I think we just need to be a bit braver.
Rachel?
I think I just wanted to link it back to the kind of prevention conversations and the frameworks. I think that's one of the reasons that we felt that we needed that kind of system level framework and clear system-wide action plans around some of this. So I think there's the mechanism for doing that, which I think you rightly said, Better Care Fund, because we've got a mechanism for what we need to agree is what we need to do. We make some brave decisions around that, and we know this will take some time to shift. I think it's your point said about bringing some of this together. I think and being clear which actions we go for first, because there's an awful lot happening. And I think we talked about physical activity fits really well in there. We do a lot of this in isolation. That was the purposes and the framework, and then having some clear system-wide actions, and then we've got the mechanisms to do that. Albeit we've got to have that difficult conversation in the middle around funding, but we can do some of this at scale by joining up a little bit better, I think.
Really helpful. Thank you for that. Laura, any final comments or points on that? We're asked to have the discussion and consider an all-year-round offer and how this might be achieved. I think Rachel's answer then talks about what's the prevention framework look like, BCF as a mechanism, demand and capacity work, all of these bits then with the activity piece that we talked about earlier need to hang together that do the so what does that offer look like and how do we build that in a resilient way, recognising pressures all year round, but also that there's always going to be in theory some resource that drops in on an annual basis that we need to then say how do we bolster or build on or develop. But I think it's the framework with the Better Care Fund as a mechanism, with the demand and capacity system work to drive the need basis piece linked to the data JSNA that then says we've got to do this in a consistent way, in a joined up way. Health and Wellbeing Board will want to be the area and the committee that the board that's got the oversight of that. So okay, Bob? Yeah. Okay, thank you all for the conversations in that. Right. We've got 20-ish minutes left. Still some agenda items to get. Louise is looking at me with that sort of pained look of chair. What are you doing to me? But I'm working on the principle for the next agenda items. People have read the reports. We're not presenting the reports and not having the conversations, discussions like we've had on the earlier items because they were for the items for the broader discussion. So I'd ask people who are presenting these to do their headline, what's the board being asked to, and then we can ask to either approve, sign off or comment on, and this should be much more around the pace of getting through the rest of the agenda, if that's okay. On that basis, Penny, Laura, Joint Commissioning Better Care Fund.
This will be really quick. I promise. So this is obviously the board have been subject to updates pretty much every single meeting on this one. Just due to timescales, we had to get delegated and previous meetings we got delegated authority outside of the meeting for both Tanya, Miles and Gareth Robinson to sign off the Better Care Fund. It's been subsequently been sent through. And as of yesterday, we've got confirmation that it nationally has had approval as well. So this is a retrospect decision, really, Simon. So if the chair agrees and the committee agrees, it's to approve the Better Care Fund and the subsequent appendices.
So we've been asked to approve the Better Care Fund that's been approved nationally and signed off. Sorry about it. I could go around the table and do that, but I think we're probably going to say yes, if that's okay. But we recognise the retrospect bit. But thank you for being quick, just to recognise the work and effort, because this has been bumpy and it's been challenging. So to get it to this point and get it signed off, thanks to you colleagues and the team for the work to get it to that point. So really appreciate it. Thank you. So approved retrospectively and signed off nationally.
It would be fun to actually not approve it. To do it this day.
Indeed. Okay, I'm going to move us on again. Safeguarding Annual Report 21-22. Tanya.
Thank you very much. So the Safeguarding Annual Report is a statutory function of the Safeguarding Partnership. Just to remind all board members, this is the Safeguarding Adults Board, Children's Safeguarding Adults Board and Community Safety Partnership Board. We're one of 3 local authorities in the country that has such a board. And the partners, as you all know, West Mercia Police, the council in Shropshire, the ICB, Shropshire Fire and Rescue and Probation Service. So the annual report is 21-22. I think to acknowledge this is a report that has been outstanding for some time. This is due to the capacity in the business unit due to sickness and other statutory functions that have had to take precedence in terms of completing safeguarding adult reviews and so forth. The board recognises that. We've got a separate meeting to discuss the capacity of the business unit moving forward. And the next annual report hopefully will be within this board before Christmas, so we get back on top of when our annual reports need to be submitted. So that's all I have to say. I think, Chair, I think the annual report clearly goes through the priorities and achievements that were achieved during that year, and the recommendation for this board is to note the content of the report. Thank you.
Thank you, Tanya, and you covered the question I was going to ask, which was the 21-22, 22-23. This might be my inability to manage my inbox. When was the report circulated?
This week.
Who?
So yeah, it would have come out from not Michelle like normal.
I couldn't find the paper.
Yeah.
That's what I'm saying. Anybody else?
It has been published, and it has. Then you will have received a notification that it's gone on, but it was later than the other papers. So
okay.
Apologies. Make sure next time that it doesn't flag.
So just so recognise, Tanya, what you said in terms of challenges of producing the reports and sickness, and note that it's just difficult when the paper's late in terms of being able to give it the due justice that we need. So can I suggest that when the 22-23 comes, we bring both of them together, have it as an agenda item and cover it off in that point. Thank you, Tanya. Okay, so then keeping us going on that basis, trauma-informed update, Penny, Naomi. Again, recognise there's a lot in this, but the report's there. Naomi, I'm coming to you first.
yeah, no, thank you very much. So
press the red button.
Thank you very much. So the report obviously highlights the work that's being driven through the trauma-informed steering group, which is attended and is supported by organisations working across Shropshire, Tapping, Wigan and Shropshire, so both internal and system partners. What I would like to draw out before we go to the recommendations is that all of the papers today that came and everything on the agenda really highlighted and demonstrated not only a person-centred approach to everything we're doing, but the fact that it's underpinned by a trauma-informed approach, and the direction that we're going nationally, that's supported by the work that we are part of in the West Midlands, is that we are developing emotionally safe spaces for people, and they're not just physical spaces, but supported by people who are aware of the approaches and the importance of asking people what matters to them. And the other thing is, this work leans into all age. This is not just about emotional health and well-being. This is very definitely linked to very definite health outcomes for people, and most specifically heart disease and diabetes, which impacts our health services, the demand in our health services, and is very clearly linked to the work around suicide prevention also. And the recommendations of the steering group and the recommendations that we'd like the Health and Wellbeing Board to support is to firstly note the progress of the work, most notably with schools, and of the steering group bringing together best practice and recommendations on how to, in terms of trauma-informed practice. So we obviously would like that noted, and the continuation of that focus as recommendations. We'd also like the endorsement of underpinning the implementation of a person-centred approach with trauma-informed approaches and care, which obviously puts the prevention and early intervention agenda very much forefront of everything that we're doing as a system. There has been a lot of talk within the steering group around the need for us to be focusing on the approach to asylum seekers and refugees. So there's a very definite piece of work coming out of the steering group around supporting, embedding trauma-informed care and supporting the development of that work and care for the people that are in our care in Shropshire, and the impact that's having on our health services, most specifically around the increase of diabetes. And the last recommendation sought is that we work together really with system leaders and commissioners to embed trauma-informed approaches in commissioning and service delivery. But that will be very definitely influenced through the work of the Strategic Governance Board of the West Midland Trauma Informed Coalition, of which we are a board member.
Thank you for that. I thought the paper was really clear. I liked how it connected to forward plan and some of the other system bits of work as well. I think the recommendations are clear. We talked about this and had the updates at this board previously in terms of some of this work as well. So good to see the progress in terms of that. I think the recommendations are clear. Any comments from board members on the recommendations as set out and as Naomi has articulated? So supportive of that and continue to bring the updates back into the board in terms of how I'm really keen to how the progress we make around that system leadership and commissioner work, to embed it in the way of the work, because that becomes routine, it becomes the norm then, rather than here's a piece of work that happens over here and we talk about. So I'm keen at the next update to think about bring an update on how that's working and what the challenges are and what the progress has been, please, if that's okay. Thank you. Okay, and then there's a chair's update. That is next on the agenda. That according to this, Louisa, I should have got to it 11:40. It's 11:42.
Doing very well. I'm very proud of you.
Don't laugh like that.
I'm sorry. She was proud of me. That's what I was like.
And I don't think I've got anything at this point to update on specifically, so I'm going to move us on in terms of the agenda, if that's okay. I'm going to pick up the pharmacy updates right at the end. So the remaining items on the agenda fall under the for information rather than for discussion. So I'm assuming people have read those. I'm going to go through and do their agenda item 13, GSNA play space needs assessment and theme GSNA. The information is in there, not being presented. Was there anything that board colleagues needed to either highlight or mention in terms of that? Nope. ICS strategy update is included as an update in there. Again, nothing to flag from there. Health protection update.
I suppose I should rightly highlight the vaccination programme has been brought forward for COVID and also flu. So just really, as a public meeting, it would be right to highlight that and just to flag that to the public, particularly at this point, and also for staff as well.
And highlight and promote.
Yes.
So I would want all of us to be really pushing the importance of the vaccination programme this year, and the earlier we can do that, our responsibility to each other as colleagues and to our family members and to our friends in terms of the availability of COVID and the flu vaccines this year is going to be really important given the challenges and the pressures that we're already under in the system. Lynn?
Just a quick question. Will there be messaging that we could just send out on our social media rather than just produce it? Is there going to just...
Yes, it's already out there.
Oh,
To make sure that we get that system-wide.
So yes and yes. Good, thank you for that. Pharmacy updates. So there's been a number of changes to the supplementary opening hours at Hillside Pharmacy and in Sandford Avenue in Church Stretton, and Boots in Hereford Road in Shrewsbury have changed their hours, and there's been a change to the pharmaceutical list. Lloyd's Pharmacy in Sainsbury's has ceased to provide services and been removed from the pharmaceutical list as of June 2023. So on that basis, I've not had any other business notified to me in advance, and not expecting then anything to be raised unless it's been notified to the chair in advance without special permission. Lynn?
I just wanted to say that we're about to publish 2 reports, one on people's experiences of making complaints across health and social care, and the other one on diabetes, which is hopefully going to feed into the diabetes transformation programme. Would it be possible to bring them both to the next meeting? I'm just conscious we don't meet as regularly as we used to, so that'd be a bit of a glut.
I see no reason why not. The caveat I would put, and it's not a no, Lynn, is we just need to, with my co-chair, look at the agenda and look at what else we've got on and make sure we just get the balance right in terms of that. But I think the request is a fair and reasonable one, and I think Cecilia will look to accommodate that as much as we possibly can.
Brilliant, thank you.
Councillor, on Teams.
Hello, very, very quickly. I don't know if this last meeting before we brought forward a paper and we talked about the work and recognised the efforts of our Armed Forces Outreach team in Shropshire. Just wanted to say that we've been nominated for a national award for the health and wellbeing category for the Veterans UK Awards, and we're off to Bristol next week. So wish us luck. It's just nice to know that all the work that we're doing is nationally now being recognised, and importantly in the veteran community. So it's just a nice little update for everyone. Thank you.
Really important, Councillor, so thank you for that, and really positive news. Of course, the key bit of going to an award ceremony is that you go and win. So no pressure in terms of that, but if you could bring back the award, that would be fantastic. Not that competitive at all in the slightest. Good. On that basis, I think I've covered all the agenda items. I think we've done all of the statutory responsibility piece that we needed to, and we've finished at 11:47. So we'll shortly go offline, but just want to thank colleagues for their contributions, inputs, and efforts, both in terms of the papers, the agenda, the debate, and the conversation. Covered a lot of ground this morning, but a lot of really good stuff. So really grateful for your help in getting us to navigate it to get to this point, and have had the conversations and discussions to then complete it on time as well. Makes my life so much easier. So thank you for that. So I think we can go officially offline, and then we'll be told when that's happened, and then